good morning everyone, and apologies again for being a little late. Start with a little video.
With the code. It doesn't look like much, just a few letters and numbers. But it's a very important code because it's about a person's health. It's about a pregnancy, a birth, a disease, an injury, an outbreak, a death. It's a code with a long and winding journey. It starts with one person in one hospital or clinic. But it doesn't end there. It joins up with other codes in databases in cities, regions, and countries. It becomes a small but important part of a big picture. It's used to monitor the health of populations large and small, to plan how services are delivered and resources are allocated, to help diagnose diseases and detect changing disease patterns. And where does this code come from? The International Classification of Diseases, or ICD. ICD is a common language used all over the world by doctors, nurses, policymakers, researchers, and many others to classify diseases and conditions so they have the best possible picture of everyone's health. Around the world, more than 100 countries use ICD to record the reasons people die, to monitor the health of their populations, and to help make financing decisions about their health systems. The world needs better health data, and ICD is delivering it. It's another way the World Health Organization is building a healthier world.
So this video was just released last week at the ICD revision conference. I didn't intend it to be as a WHO promotional video, but I thought it's a nice way in which sort of, individual health data collection. This is not mine. Links to population health. So I was asked to sort of set the stage a bit and looking at monitoring mortality in the context of the Sustainable Development Goals. And I think I don't need to tell anybody that mortality statistics are, by age, sex, and cause, are the foundation of public health globally and in countries, and we need comparable statistics over time. Also, I think now with the Sustainable Development Goals 2016-2030, we have added impetus in this area, because there are loads of targets and indicators, but in their mortality goals are very explicit. The health goal overall is ensuring healthy lives and well-being for all at all ages. And within there we have a number of course-specific mortality targets around NCDs, violence, maternal mortality, child mortality. But also in other goals there are specific targets and indicators for course-specific mortality. So hopefully that will be an impetus for greater investment in this area. Because in my next slide I will summarize as we see the situation in 2015. So in the world there are an estimated 56.6 million deaths, and of those just about half are registered, so have a death certificate, so half is not recorded at all. Among those 27 million deaths reported to WHO, which is mandatory, all countries need to report mortality by age and sex and cause using the latest classification, we have about 20 million. And then if we look at the data, whether the ICD code is used, we're going down to 16 million. And then if we evaluate the quality of those data, we're going down to 14 million. So actually only 1 in 4 deaths in the world have a proper ICD code in 2015. If we look at it over time since 1950, it's when the database started at WHO, there have been some improvement over time. This is the number of countries reporting ICD over time by income group, and the very small the purple top at the top are the low-income countries. So virtually there's no reporting of ICD, causes of death using the ICD by low-income countries at all, and also lower middle-income countries, which is a big group, including India and others, is also quite small. And also if you sort of say, well, 100 countries are reporting out of the 194 member states that we have, there doesn't seem to be much progress over the past few years. That decline at the end is just a delay in reporting. We think it's perhaps creeping up a little bit, but no dramatic improvements. So in countries with well-functioning systems, mortality statistics based on death registration and using the WHO medical certificate of the cause of death that's completed by physicians or coroners is the standard. And coding is done by trained coders or with automated coding tools such as IRIS. It's now been, the ICD-10th revision has been translated in 43 languages and is used for many other things, not just for mortality, also for morbidity, for health financing like reimbursement through insurance, etc. So just one slide on the history, because I just come back from this ICD revision conference, which is the 11th revision. And basically, the ICD has been around for more than 100 years. Actually, of course, the Bill of Mortality, William Farr, goes back much longer. But the first statistical classification was in, I think, 1896. And then the ICD is existing more than 100 years. And almost every 10 years, there was a revision up to 1990 when the ICD-10 was released. But the ICD-10 stayed around for a much longer time. And now we're really working on the arrival of ICD-11, which is supposed to be launched by 2018. If you look at the complexity and the number of codes, in the first years, it was around 200 codes. Then in the 1950s, morbidity statistics came in. It was first only a statistical mortality classification. It jumped then to nearly 1,000. And then in 1967, it became mandatory for countries to report using the latest version of the ICD. Then you see further increase, and currently we're struggling with 6,000 codes and trying to bring that down in ICD-11, because that, of course, is a very hard to manage number. Although with the information technology now getting introduced in many ways, it will become a lot easier. And there is now a foundation layer of the ICD, which in fact contains 47,000 diseases and symptoms, signs, etc. So it's getting a lot more complex, but I think that ICT can help us a lot with that. So that's enough about the ICD, because really the problem I think that we're talking about here is that 75% that doesn't have an ICD code. But we need to somehow improve mortality and cause of death statistics in the next 15 years in a rather dramatic way, something that hasn't been achieved in the past decades at all. And in fact, there hasn't been much progress. There has been massive progress in modeling, but not so much in data. So there are basically 4 data sources that one could use in countries with inadequate civil registration and vital statistics systems. Health facility data, household surveys and census, health and demographic surveillance studies, and then sample registration systems. None of them is perfect, so the idea is to really put it all together and then come up with the best possible estimate of what the cause of death pattern is in a country. So briefly on each one of those 4 items. So on the health facility data, I think we have long said, the majority of deaths are in the community, and therefore we must solve that problem first. And I think we're now realized that let's take the low-hanging fruit first and at least have countries report and collect proper data on cause of death patterns from hospitals. And every country, low-income country, I'm talking about mostly Africa and Asia and some Latin American countries, list the top 10 causes of death every year based on data from hospitals. But those data don't make any sense. And there's a lot of unknowns and so on. They don't use the ICD. And so we fought long with the ICD community because they resisted the idea of a short list. And so finally, last year, a breakthrough, we managed to get what we call the WHO startup list of mortality, small, which has 107 causes. And that, of course, is much more attractive to use for countries. Adapting of the training materials for certification is an essential component of this, because if this medical certificate is very poor, the coder can't do much in terms of improvement. And then perhaps, and what is perhaps the most exciting aspect of it, is integrating this startup list of causes of death into DHIS, which is the District Health Information System, a system that's now used by more than 50 countries. It's basically aggregate data analysis at the data entry at the district level, putting it all together nationally, all the health facility data. But in this case, they're entering individual data for each cause for each death with a probable cause. Obviously, the drawback of this, there's a limitation. Less than 30% of deaths take place in health facilities in most countries, and sometimes less than 10%. And then the causes, obviously, are the causes in hospital, and they're not representative for the national population. But it's a start. It's an important start. And it gets ministries of health excited because it's their data. The second source, very briefly, household surveys and census, obviously a major source of data on levels and trends of adult and child mortality through birth histories and sibling histories and other demographic methods. I don't have to say that here, being sort of near the birthplace of the indirect methods with Bill Brass. Causes of death, maternal mortality has really taken off through the demographic and health surveys. And in fact, it was maternal mortality that got more adult mortality data collection through sibling survival histories and not the other way around. And this happened in the early 90s, but with considerable noise. And then some countries use verbal autopsy modules in surveys, either during the survey or after as a follow-up. And then there is also the odd example of a post-census mortality survey like Mozambique in 2007, which did verbal autopsies on more than 3,000 deaths. Drawbacks are that, of course, these are not continuous data, mostly once every 5 years. You can't disaggregate it too much. And then verbal autopsy modules are not used much. They were used a bit in the early 90s. Then there was a sort of vacuum. And now I think there's renewed interest in it. But it does only give you a very crude picture, because you're dealing generally with 300 to 500 deaths or so. So break that down by age groups and sex and then causes, and so you get very small numbers. I won't say much about the third source, the health and demographic surveillance studies, because I think we have two experts in that area here. But the in-depth network with longitudinal studies in a country with variable populations. So these are localized epidemiological community studies that can generate vital statistics. I think they have become better to provide those very quickly to governments so they can add it to other data on vital statistics. I think they're useful to look at trends by age and sex and often include verbal autopsy. Of course, it's only a local population, and there are sometimes special features related to the funding or the selection of the site. But I think some real good work has been done by Don de Savigny to try to use data from these sites to create mortality profiles for sort of the epidemiology and planning in other districts. And then lastly, sample registration systems. For a long time, limited to India and China. But recently we've seen several efforts in sub-Saharan Africa, also Indonesia, to set up systems. And also we've seen some systems perish when the funding finished. But Global Fund and some others have been funding it. And I think the Gates Foundation is also interested in supporting some. It provides nice trends in mortality and cause of death patterns, because verbal autopsy should be included. And if it's implemented, it should be supporting the civil registration vital statistics systems, and I'll come back to that. But if a country needs continuous vital statistics, including causes of death, in the relatively short run over the next 15 years, this is the only way, in my view. That's for discussion. But that doesn't mean the other sources need to be neglected. They also need to be done. So, in summary, enhancing mortality statistics during the SDG era means strengthening the civil registration and vital statistics systems. There's good political momentum for increasing birth and death registration. Unfortunately, I think there was a bit more momentum a few years ago, and I hope that the SDGs are going to sort of get that momentum up again. And there's also a tendency to focus more on birth registration as a human right and directly linked to interventions that are particularly of the interest of global initiatives such as Gavi, Global Fund and so on, to do more of that and then forget the death registration, because the death registration is not very sexy, except for us, I guess. But so this must be the first step. But these systems will not generate good vital statistics until a decade or so later, in my view. And then while doing that, also obtain cause of death data from facilities and communities. So work on that at the same time. Establish a sample registration system, as I mentioned, because one gets national trends and one can have a few strata. Obviously, one can't have it for every province or even smaller units, but one could have meaningful strata and include verbal autopsy in there. And I think it's a question whether it should be everywhere or not, because obviously it adds significantly to the effort. But, Philip Settle, I think, called this SAVI, sample registration systems with verbal autopsy. And there are a few countries that do it, like Tanzania, Zambia is planning it, Malawi. And then continue the mortality data collection in household surveys and health and demographic surveillance systems, but try to link it as much as possible to the CRVS strengthening. Now, you can't see this, but I just wanted to show this, that developing a civil registration and vital statistics systems that includes verbal autopsy for death in the community, which we all think is essential, is something that needs to be thought through in quite some detail. And Don de Savigny and some of his colleagues have thought this through, and I think there's a paper just submitted that thinks about all these different aspects. So finally, I think improving the cause of death in the CRVS system strengthening. So I said already the hospitals using electronic systems, implementing the verbal autopsy in sample registration systems using the WHO 2016 standard instrument, which has been developed in collaboration with a lot of experts like Peter. Use the cause list for the short list. There's a shorter list for verbal autopsy as well, but it's mapped on the ICD, because if you don't do that, you can't put all the data together. And then think about analyzing, using analytical tools such as InterVA, Tariff, or physician coding, which perhaps you will also talk about, which is a good way. I don't think there are strong evidence that physician coding is much worse, but it does cost more money. And then the analytical capacity to put it all together. And I think that's something that needs to go in parallel. So final slide, so it links to the SDGs. So the SDGs have 169 targets, so everything under the sun is there. And just the very last of the 230 indicators is indicator 1719.2, which came in because of the African member states. They really pushed for it. And it reads, proportion of countries that have conducted at least one population census in the last 10 years and have achieved 100% birth registration and 80% death registration. That is by 2030. We were a bit more ambitious like 2 years ago when WHO and the bank put out a global investment plan for CRVS scaling up with a lot of involvement of countries. The targets there were for 2020 pretty much the same as the targets we have now, but I think it's fairly realistic to move the target to 2030. So setting over-ambitious targets is also something that we suffer from. But if they're not ambitious enough, we get punished for that. Thank you.